Hi, I'm Autumn Sanderson, and this is video 3 of my gold standards for COPD exacerbations for respiratory 2480. In this video, we are going to be talking more about maintenance therapy. So just to introduce the video, we are going to be talking about drug therapy, med groups, and initiating ICS. For drug therapy, patients with COPD are going to be prescribed a short-acting bronchodilator. These are going to be our drugs that are going to be used as needed. So we have our short-acting beta agonists. These are for a quick relief of shortness of breath. We have our SAMAs, and these are going to relax our airway muscles to help us breathe better. And then these also can be used together in combination. Patients are also going to have a long-acting bronchodilator, and these are going to be for our more persistent symptoms. We have our LABAs and our LAMAs, which are going to both help prevent exacerbations, and they can also be used in combination for patients who have frequent exacerbations. Patients will also be prescribed an ICS, an inhaled corticosteroid, for frequent exacerbations. And an ICS is going to reduce inflammation in our airways, making it easier for our patients to breathe. And patients with severe COPD are going to have both an ICS and a LABA. But we want to limit our inhaled corticosteroid use in COPD patients because there is a risk of developing pneumonia. So, like I said in video 2, not every patient's maintenance plan is going to look the same. Every patient has their own set of symptoms, their own lifestyle, their own requirements, and some patients do not do as well with an ICS as other COPD patients might. However, most of them that I've seen at least will have an ICS. We also have combination drugs, and these are for our very severe COPD patients, and these are going to get the triple threat. They're going to get the LABA, the LAMA, and the ICS. Additional drugs, if needed, would be our leukotrienes and our expectorants to kind of help us get all of that extra sputum that our COPD patients have stuck in them. We want to get that out. Med groups. So our med groups are based on our GOLD guidelines, and it goes by a progression of the disease process. So we have 4 groups, A, B, C, and D. Our A group, that is going to be our patients with mild COPD. They're going to have minimal symptoms and minimal exacerbations. They're going to get a SABA or a SAMA, so that's short-acting drug. And then we have our group B COPD patients. They have a moderate case of COPD. They're going to have more symptoms than group A, but still a low amount of exacerbations. These patients are going to have a LABA or a LAMA, so long-acting, or both. And then our group C patients, these are where we're going to see more of our severe cases of COPD. They're actually going to have less symptoms, but more frequent exacerbations. And these patients are going to get a LAMA. And then we have group D. These are our super severe COPD patients. They have many symptoms, frequent exacerbations. They're going to get the triple threat cocktail of a LABA, a LAMA, and an inhaled corticosteroid. So when we initiate inhaled corticosteroids, we're going to use them in combination with a LABA or a LAMA, and this is going to reduce the number of exacerbations in a severe COPD patient. However, other things could be affected. So there are positive signs to inhaled corticosteroids, and then there are negative signs and symptoms with inhaled corticosteroids. So some good things that come about besides reducing the number of exacerbations is it's going to improve dyspnea. Patients even say that it helps improve their sleep, probably because they're sleeping or they're breathing better in their sleep. And it's going to have an improved airflow, so it's not going to feel as difficult for patients to breathe. But some cons. So, oral flush is going to be a big thing that can come about if patients are not taking their inhaled corticosteroid correctly. If you're not rinsing out your mouth immediately after that, that could cause oral flush. And we don't want to cause any more problems than we already have. And also, it can affect the skin. It can cause skin to thin. It can cause bruising to easily happen. There's some other cons too that there isn't a ton of research on them, but people say that inhaled corticosteroids can cause other issues related to diabetes and other conditions. But from what I've seen in a clinical setting, one of the biggest takeaways is always make sure you flush your mouth out with water so that you don't get oral flush. And these are my citations for video 3.